Hello and good morning, everyone. Today, this lecture is about hematology, and to tell you the good thing about pediatrics is most of the topics which you have done in detail in internal medicine, they are same in pediatrics. So, for example, hemolytic anemia, iron deficiency anemia, as well as sickle cell disease and megaloblastic anemia, or if we will talk about bleeding disorders or immune disorders, they remains the same. In short, there is no difference between these conditions and the treatments as well. uh, at this level, the important thing in pediatrics is the dosages of many drugs, but no one is going to ask you the dosage of the drugs at this level or undergraduate level. Of course, that's an important thing. So of course, that's one of the reason. uh, Simply you can say that they have given just one lecture uh, for hematology in pediatrics, but um, I'm uploading these lectures on the YouTube, but uh, I don't know. There are many people who are not who are not my students, and they see these lectures and they say they ask questions which are not relevant. For example, um, there is just two lectures for hematological disorders, right? Or now, like in two lectures, we cannot cover all the conditions. You can say um, like about all the conditions like iron deficiency anemia, what is hemolytic anemia, and all this stuff. So that's why I'm telling you, like, whatever you have done in internal medicine, the things are same. So I will be talking about the differences most of the time. So as when I was teaching you neonatology, I told you that um, when the babies are born, like inside the fetus, like when inside the womb, when it's a fetus, so they are living in a quite comparatively hypoxic state when as compared to when they start breathing and they are using their own lungs to breathe. So at birth, basically the HB level or the hemoglobin level is high than uh, what you can say uh, like sorry, like let me select the right kind of slide which I want. Okay, so at birth, by the way, what happens is uh, there is high HB count, and as soon as after birth, when they started breathing on themselves, so their HB become down. So the newborn have high HB, high hemoglobin. It is greater than 170 gram per liter. And what happens then after 2 weeks, 3 weeks, 4 weeks, 5 weeks, and so on, like it keep on decreasing. There is more and more breakdown of RBCs, and like the HB changes as well. Like there is HBA, which is the adult form, and there is HBF, which is the fetal form. So that have to change as well. So simply uh, at birth, because of more hypoxic conditions inside the uterus, soon after birth, there is shorter lifespan of the RBCs, and also there is decreased production as well during the first 2 months of life, approximately, right? Like this is the time. And basically, for the first 2 months, you can say there is virtually no erythropoiesis going on, because there is a lot of cells, and most of them they are broken down, and The body is now in oxygen rich environment, so that's why the body don't need it. So that's the reason. And that's the reason, like around, you can say, 8 to 12 weeks of age, which is the 2 or 3rd month of their life. So 8 to 12 weeks of age, uh, the hb fall down to the hb fall down to around 100 gram per liter. So this is the lowest levels, and this is called as physiological anemia. Okay, so I would rather at birth. So this is called as physiological anemia or physiologic anemia. No treatment is required for this thing. No treatment required. Okay, this is a physiological process, right? So this is the most important concept, like you must note. And then I would like to talk about the causes of anemia. By the way, the slide which I will share with you guys, it have like more than 217 ppts, 200 ppts plus. And uh, like you can just go from any textbook. That's better than going through the slides. So anyhow, anemias are classified again. How the anemias are classified is like what you have done in internal medicine. First of all, you can see we see like okay, if you want to know like how we interpret the blood reports in anemia, you can open the diagnostic playlist and you can see there how to interpret the blood reports in anemia. So the first thing we see, like either there is increased reticulocytes count or decreased reticulocyte count. So if the reticulocytes counts are increased, so it means like the body is producing more and more cells. The reasons could be two: blood loss or hemolysis. And whenever it is hemolysis, so the hemolysis could be due to causes which is intrinsic to RBC, like the problem is lying within the RBC, or it could be extrinsic to our RBCs, like something outside from outside is causing hemolysis. So whenever the causes are you can say related are intrinsic to RBCs, so there could be three kind of defects, you can say. Like number one is what, there could be hemoglobinopathies, right? And for example, it could be sickle cell disease or thalassemia. Now the thalassemia which you have done in internal medicine is the same one: beta thalassemia minor, beta thalassemia major, and alpha thalassemia. All things remain same, and sickle cell disease will remain same. There is no difference. It could be a problem with the membrane protein, like hereditary spherocytosis. Now, what is hereditary spherocytosis? Hereditary spherocytosis is basically what happens in this one. Um, in these patients is what, like um, the RBCs are sphere shape, round, rounded shape RBCs, right? Like spheres. That's why it is called as spherocytosis. Like the sphere shape RBCs are too much in the blood. It is the most common type of hereditary hemolytic anemia. And the problem is in the RBC's membrane protein called as spectrin. So what happens because of that defective protein, spectrin? The RBCs become rounded shape. You remember, like normally the RBCs are biconcave shape. So here they are rounded shape. So now the biconcave shape can stand a lot of, you can say, stress. It can be squeezed through the capillaries, but when the RBCs are sphere shape, so they are more fragile, and whenever they pass through the spleen, they get destroyed. So simply there is hemolytic anemia due to spectrin. Now, when we see their blood film, the blood film shows spheres simply, and we can do a test called as osmotic fragility test. And the treatment is simply we go for splenectomy in these patients. Splenectomy, like removal of the spleen, of course. That's the only thing we can do in these patients. So this is like hereditary spherocytosis. Same like this thing, we have one more thing called as hereditary elliptocytosis, in which the RBCs are eclipse shaped. And now sickle cell anemia, I don't know like how much you know about that, but it's the same condition which you have done in internal medicine. It's an autosomal recessive type of condition in which there is, uh, like at chromosome number 11, the glutamine is substituted for valine, and that's the result. We call it as HbA. Now we call this one as HbS, hemoglobin S, and the cells are sickle shaped. That's why we call it as sickling disease or sickle shaped sickle cell disease or sickle cell anemia. And it is common in Mediterranean people, the people who live in Mediterranean region. Now, basically on chromosome 11, there is an allele which is present, which is controlling this thing. So now, so many people, they are homozygous of this thing to this thing, and many people are heterozygote. Okay, like heterozygote means what? Like they have both the normal and abnormal. Homozygous means what? Like both of them, they are abnormal. So simply, what happens that because like they have sickle shaped, and whenever like there is any stressful condition to the RBC, especially low oxygen, the hemoglobin S polymerizes, leading to the formation of a rod-like crystals that looks like sickles. And this sickles or these sickle cells, what it do? It causes injury by hemolysis, and also it causes occlusion of the small vessels. So there could be ischemia also. So that's why anyone, of course, who are heterozygous, we call that condition as sickle cell trait. And whenever they are homozygous, or like they have both of their genes are defective, then we call it as sickle cell anemia. And they have like again anemia. They like in neonatal period they have more jaundice, more pronounced jaundice. They get splenomegaly, and so whenever the patients go into stressful condition, they develop crisis. We call it as sickle cell crisis. So what happens is like during any toxins or infections, what happens, like there is more and more cells which get destroyed, the get dropped, the spleen become enlarged, and whenever it started damaging the small vessels, or vaso-occlusive type of events will occur. So what will happen, there will be ischemia. So ischemia to the chest, ischemia to the abdomen, ischemia to the extremities. So they present like this. They may have stroke and things like this as well. So simply, investigations remain same. We can see it under the microscope. We found like that is sickle cell, and we go for electrophoresis. So electrophoresis, of course, it can distinguish between different type of HBs. So this is what happens. Now, of course, like whenever anyone has sickle cell crisis, we what you can say, we give them supportive as well as some drug treatment. For example, uh, there is a drug called as hydroxyurea. So a hydroxyurea can be given to these drugs. So basically, hydroxyurea do what? It increases the production of HbF. Okay, and also like if someone have vaso-occlusive crisis, like the small uh, vessels, or they are becoming occluded, so they are the one, we provide them oxygen, we provide them more hydration. Why hydration? Because we have to make the blood dilute, or we have to reduce the viscosity. They have pain, multiple areas, back pain, chest pain, so analgesics can be given, and exchange transfusion can be done. So this thing, and most of these patients, their spleen get enlarged, so splenectomy can be can be one of the thing we can do. So This is about sickle cell disease and hereditary spherocytosis. Now, thalassemia is a very, you can say, common condition, around the world. And what happens in thalassemia again? This is a type of hemoglobinopathy, same like sickle cell disease. In sickle cell disease, there is HBS. Okay, so normally we know like HBA is the normal one. HBA have two alpha and two beta chains, and whenever it is like there is any abnormal HB like sickle cell disease. So in thalassemia we can have now normally hemoglobin HbAs have two alpha and two beta. So that's why thalassemia is of two types. One is alpha thalassemia, one is beta thalassemia. So alpha thalassemia, of course, when there is mutation in the alpha chains or change in the alpha chains, and beta thalassemia when there is change in the beta chains. So that's how this thalassemia it occurs. Now everyone like there are many easy ways to remember the things about thalassemia. For example, I have like my own ways of remembering like what is alpha thalassemia, what is beta thalassemia. But simply thalassemia is defined as, you can define thalassemia as defects in production of alpha or beta chains. And now alpha chain thalassemia, remember A for alpha and A for Africa and A for Asia. So remember alpha thalassemia is more common in Asia and Africa. And beta thalassemia same like SCD. Sickle cell disease, it is more common in Mediterranean people. So now whatever is there, one important thing to know here is what? There is hemoglobin genes on the chromosomes. So just give me 1 second. I want to see like if there is anything on the Bing like related to thalassemia, if we can found anything. Okay, so now for example, um, yes, this one. I don't know which language, but uh, okay, leave it. Okay, so alpha thalassemia, like better to add one more slide. Okay, so alpha thalassemia, uh, there are four alpha genes in total. Okay, and normally there are two beta genes are there, genes in total. Okay, so simply this one is present on chromosome number 16. Okay, this one is present on chromosome number 16, and this one is present on chromosome number 11. And now actually I remember it by this one. This is 2, so 1 and 2, and this is 4, so 4 multiplied 4 is equal to 16. So that's how I remember this one. So now there is we could like when the hemoglobin have 2 alpha and 2 beta, we call it as HbA. When the hemoglobin have 2 alpha and 2 gamma, we call it as HbF, right? So normally and there is HbA2 as well. So normally we have around HbA in the blood, around 97% in the adult blood, and the rest is HbA2. The 3% which is left is HbA2. Okay, so normally this is like how our blood is there. So what happens? See, HbA have two alpha and two beta, two alpha and two beta chains, and the genes which are controlling what you can say the alpha chain. There are four genes, okay, and the genes which are controlling the beta chain, there are two genes. Now, see, For example, if we will talk about the beta thalassemia, okay, beta thalassemia. Now, what is beta thalassemia? Of course, there will be problem with the beta chain. So when there is one defect in one single gene, single allele, you can say, of beta gene, what it means, like, of course, like, the person is heterozygous. Like, he got one normal beta globulin allele and one abnormal beta globulin allele. So simply their genetic makeup will be how like there are two alleles, one is defective. So simply, uh, we call this thing, when there is just defect in one single allele of beta gene, we call it as beta thalassemia minor. Okay, very common in Mediterranean people, and this is usually asymptomatic. Because why? One allele is there, so it will keep on working. Okay, the only thing is, they have some anemia. Okay, and remember, thalassemia give microcytic anemia, and the level of HbA2 in them, which is normally around 3%, is basically more than 3% in these patients, but they remain asymptomatic. They don't have anything. Now, whenever there is defect in both alleles, so now see, beta chain is controlled by two alleles. Both of them, they are defective. So now it is, or you can say it is homozygous. They are homozygous for the defect. So it is autosomal recessive. Of course, like, we need both of the alleles to be defective, so it is autosomal recessive. So now there is ineffective synthesis of chain. So now the chain will be defective. So we call it this thing as simply beta thalassemia major. Now, guys, these are the patients who will be having sign and symptoms. What? Like, they will be having anemia, they will be having severe jaundice, they have defective erythropoiesis, they need multiple blood transfusion all their life, they have stunted growth, they have organ dysfunction, they have hepatomegaly, their bones are not normal. So simply they have all these things. So they have severe type of anemia as well, and because they need repeated blood transfusion, so what happens, like, with time, they develop iron overload, or iron overload. Iron can get deposited into the joints, into the pancreas. So we call it as, like, they may have diabetes because of that. So of course, like, they need lifelong transfusions. And with transfusions, because they develop iron overload, so we keep on giving them iron chelation therapy. We keep on giving them deferoxamine or iron chelator simply. Plus we give them folic acid supplementation, and these are the patients in which, like, the only treatment is what you can say, um, stem cell transplantation. Okay, so now comes the story of alpha thalassemia. Now, in alpha thalassemia, what is there? Now we know from our knowledge that, there are four alleles uh, which are controlling this alpha thalassemia, right? So now the thing is, can be understood by this way. Yes, I was searching for something like this, yes, and finally I found it. Okay, let it make clear. So until then, we can discuss. Okay, yes, finally it is done. So to make you understand alpha thalassemia, I think we get the best, what you can say, representation with all the clinical representations. Now we know that alpha thalassemia, there are four alleles which control, right? So see, A1, A2, A3, A4. Now see, there are four things. For example, one allele is defective, two are defective, three are defective, or four are defective. So when there is just one allele is defective, so see, just one is defective, okay. So what is going on to happen? Like, they are clinically silent because they have normal hemoglobin and normal MCV even. So one of the four alpha globin allele is deleted, which could be in any fashion. So minimal decrease in alpha globin synthesis. So remaining three functional alleles synthesize adequate alpha globulin. So simply, they are the silent carriers. They are clinically, and see, normal adult hemoglobin is 96%. Like I told you, 97% hemoglobin A, 2% hemoglobin A2, and 2% hemoglobin F. Okay, which is a fetal hemoglobin. So this is all the information which I was writing. It is given in this one. Now, the other one can be two defective alleles. Now this one can be, uh, if this is the type of presentation, this is called as cis, CIS, and this one is called as trans. So this is the cis, this is the trans. But simply, you can say like out of four, two are defective. So now these are the patients who have decreased MCV but normal HP. So they present with mild anemia with microcytosis, but most of the time they don't have even microcytosis. This is called as alpha hemoglobin trait. Okay, and most of these patients, they generally remain fine. By the way, this cis type, this cis type is more common in Asians, and this one, trans one, is more common in Africans. So whatever is there, guys, what happens is, like, simply they 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 have their occasional RBCs contain HBH inclusion bodies or superal stain, now diagnosed with molecular testing, but simply they have mild anemia with microcytic hypochromic RBCs, normal HB electrophoresis, and so they remain normal. But when there are three defective genes, now this is called as HBH. See this one, HBH disease. And what happened? These are the people who have moderate anemia with microcytic hypochromic RBCs. Okay, they have splenomegaly and things like this. Whenever all the four that genes are affected, we call it as HB BARTs or hydrops fetalis. Okay, and this is usually incompatible with life. They are born dead. So simply, one or two defective genes, they doesn't need any treatment, but they need genetic counseling, because if they you will not give them genetic counseling, of course this condition can be um, can come later on, right? HBH, this one needs treatment, and the treatment is like, you can say, similar to the, what you can say, thalassemia, which we have discussed already, and this one is, it is incompatible with life. Okay, so this is about the thalassemias. Now you can see over here, one thing is called as G6PD deficiency. Now what is G6PD deficiency? uh, Quite easy. uh, Whenever anyone have G6PD deficiency, now if you have done biochemistry in a good detail, you must know, this is the name of the enzyme called as glucose 6 phosphate dehydrogenase. So basically what happened, uh, in G6, like whenever there is G6PD deficiency, so they have basically uh, lack of reduced glutathione. So simply, whenever there is any oxidative stress and whenever the RBCs go into any stressful condition, the RBCs, they get burst. Okay, if you want to go and see like what is G6PD or glucose 6 phosphate dehydrogenase, guys, go and open biochemistry books and try to read about glucose metabolism with pentose phosphate cycle, and then you would know, like, what is the role of this one. So simply, these patients, they are completely normal, but whenever they are under any oxidative stress, like, and they take some drugs like antimalarial sulfonamides or nitrofurantoin, or they have infections, you know they present with hemolysis. Their RBCs get broken down. Treatment is diagnosis is simple. We can do G6PD assay, and that's the reason, in many of the countries, Mediterranean countries, when they are going to give some drugs to the patient, they always check G6PD enzyme in them. Treatment is simply we give them folic acid, or we should stop the triggers like drug or whatever is there. We should stop that. Okay, so the treatment is quite simple in these patients. Other than that, so this is like, you can say, the problem is intrinsic to RBC, right? So either it's a membrane problem, either it's an enzyme problem, either it's hemoglobinopathies. There are many other things like pyruvate kinase deficiency and stuff like this, but of course we have to discuss the important one. And by the way, to tell you the truth, like what I have seen, if there is just two hematology lectures or one hematology lecture, uh, what the what it is usually done is like they just teach, for example, iron deficiency anemia, and they just go. Okay, so I don't think so that's a nice idea, because you already know what is iron deficiency anemia. So instead of discussing that, I am trying to cover, give you an overview about like how the conditions, they behave like. So now, whenever it is, you can say hemolysis. Now, hemolytic anemias, whenever hemolytic anemias are there, so we always check uh, like either it's immune mediated or non-immune mediated. So immune mediated, of course, we do Coombs test, and the Coombs test will come back as positive. So of course we can found some antigen antibodies, and non-immune one are those like in which the Coombs test is negative, like um, uh, thrombocytopenic thrombotic purpura or hemolytic uremic syndrome. We will discuss these conditions. So simply, what happens like in hemolytic anemia, the RBCs, they get destroyed. Like normal lifespan is around 120 days, but in this one hemolytic anemia, the RBCs lifespan is less than 120 days. Right? You can say less than 100 days or sometimes 60 days, right? So immune mediated can be warm versus cold autoimmune hemolytic anemias, and non-immune ones are those which can be caused by some other reasons, like I told you. DIC is one of the example. Has TTP, vasculitis, different type of vasculitis, or for example, someone have hypersplenism. Okay, so this thing. Increased reticulocytes. One thing is hemolysis. We discussed this thing. Then other thing is blood loss. Of course, blood loss can be catch in the history. Someone who have a recent trauma, someone in which like they have some bleeding disorder, and they lose a blood on multiple occasions and on multiple times. When the reticulocytes counts are decreased, so now we know that there is some production problem, like the RBCs are not like the production is not going on. It could be normocytic, it could be microcytic, it could be macrocytic. Now whenever it is microcytic, the MCV is less than 80. Whenever it is macrocytic, the MCV is more than 100, and between 80 to 100, it is called as normocytic. Now, microcytic anemia, remember there is a very good mnemonic called as TAILS, though I don't like it because in TAILS, I comes on the third number, which is the most important cause. So if you can remember, like the iron deficiency anemia is the most common cause. Remember, it is iron deficiency anemia, thalassemia, anemia of chronic disease, lead poisoning, and sideroblastic anemia. Whenever it is macrocytic, we see the megaloblastic changes. So remember, vitamin B12 deficiency, folic acid deficiency. They are the one which give megaloblastic anemia. Rest alcohol, drugs, and many other things can give macrocytic anemia. And normocytic, renal failure, bone marrow infiltration, and anemia of chronic disease. They are all the causes of uh, normocytic anemia. Now, too, if we will talk about, for example, iron deficiency anemia, um, you can go through the slide, guys. In this slide, there is too much details of iron deficiency anemia is given. with all the introduction. This is the most common one. This is the most common cause of, you can say, childhood anemia. Now you can, of course, I will send you the slide so you can see the slide, but I will tell you a few of the things, uh, like like the clinical points. This is the most common cause of anemia worldwide. Okay, and basically we have, like, the babies, they have reserve of iron in their body, but one thing, when the babies, they are fed on cow milk, and for example, due to poverty, uh, like, I'm talking about the developing countries, of course, like, they are fed on the cow milk. They cannot buy the expensive marketed milk or the powdered milk or formula milk. So we must give them some iron fortified cereals, like red meat, or like we should give them some food like red meat, and like all these things, which have iron. So see, foods to avoid an excess intolerance is too much cow milk. If you are giving them, give them some iron supplements also. Tea, basically, it inhibits the absorption of iron, and high fiber foods like phytates, they inhibit iron absorption. Now, whenever the babies, they are premature, they are low birth weight, they are low socioeconomic status, they are more commonly have the risk of developing iron deficiency anemia. Cow milk is one of the thing, or you are not providing them with enough fortified diet. Uh, this is the iron transport thing, very, very, very important. So the important thing which I would mention here is, now, not these are the only causes. Of course, like, blood loss comes as well. So for example, someone who is losing too much blood, or for example, someone who have a cow milk protein allergy, or someone who have a chronic disease, they can all present with iron deficiency anemia. Now, guys, of course, like I told you, that this slide, like, there is almost everything is written about iron deficiency anemia. So what I would like to say right now about iron deficiency anemia is, they present same like adults. They present with pallor, though they have some specific things like pica, pica. Pica, what is that? Like, the children, they started eating non-nutritious things like pencil, word, things like this, right? So we go in the same way as we go for the iron deficiency anemia in adults. Like, we go for CBC, we go for MCV, we go for MCH, we do the iron studies and all this stuff, right? The importance is treatment now. Okay, how we can prevent it? Always tell the uh, educate the people that we must provide with iron supplementation, especially when you are weaning off or putting them on cow milk. Give them iron fortified formulas or iron fortified cereals. Okay, especially premature babies. Try to avoid cow milk. If there is buttermilk, of course, give that. Give them the vegetables which are rich in iron, and simply give them balanced diet. Now, when the thing cannot be solved by that, so we start giving them iron. Of course, it comes in syrup form as well. So simply, um, once we put them on iron, we give them 6 milligram per kg per day, and we keep on checking, like, either the reticulocytes are increasing or not increasing, right? So that's the important thing, because iron deficiency anemia should be treated, and of course, like, because they are developing neurologically, they are developing, so they must have no deficiencies in the body, and all these things, they are the same type of anemias like what we have done already. So this thing is important. um, I don't think so I left anything unturned over here. I think I talk about vitamin vitamin B6, B12 deficiency anemia, megaloblastic anemia. So of course, like, provide them with that thing. Vitamin B12 deficiency anemia is will give megaloblastic anemia. It is not so common in children, so that's why like I'm not talking about that. Okay. So the next thing is okay. One of the thing is bleeding disorders, okay, or the disorders of hemostasis. Now, guys, I will first of all I will show you what are the causes of hemostasis, like or primary hemostasis disorder. Then we will talk about the secondary hemostasis disorders, right? I always say one thing that it's very important to know about what is primary hemostasis and what is secondary hemostasis, and to tell you, um, the primary hemostasis is basically what you can say. If you know what is hemostasis, there are stages of hemostasis. A primary hemostasis is basically when the platelets they form a plug and stop the bleeding. And then there is secondary hemostasis problems in which the platelet plug, which is formed in primary hemostasis, should be converted into a fibrin clot, right? So now, um, of course, the primary hemostasis it is to form a platelet plug, and if you know all that physiology, then you would understand that these are the three type of things which can cause abnormalities in the hemostasis. Like platelet causes can be there, von Willebrand disease can be there, or vascular problems can be there. And if we will talk about the problems with the secondary hemostasis, so remember secondary hemostasis in which the platelet plug should be changed into a fibrin clot. In that one, all the clotting factors are playing the role. So remember, whenever it is about the clotting factors, so clotting factors are proteins and they are formed in the liver. So first of all, there are some certain conditions. If you know about very 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 common disease, even the layman they know about that condition, that is called as hemophilia A and hemophilia B. So what is hemophilia A? It is factor 8 deficiency, and what is hemophilia B? It is the factor 9 deficiency. And then there could be deficiency of factor 11. Then there could be liver diseases, there could be kidney diseases, there could be vitamin K deficiency. Like all these factors can cause disorders of the secondary hemostasis. So here in front of you is the primary hemostasis disorders. Number one, we like okay, one very important concept is what, like, whenever there is any primary platelet or primary hemostasis disorder, or simply there is thrombocytopenia, like the platelets are less. Like I'm giving you one example of the primary hemostasis causes. So remember, the patients they present with petechias and purpuras, or you can say the superficial bleeds, petechias and purpuras, or superficial bleeds like epistaxis or menorrhagia in females. But whenever it is secondary hemostasis disorder, which means that the clotting factors are the one which are defective or which are absent, like hemophilia A or hemophilia B or hemophilia C or vitamin K deficiency or liver disease, all these things. Remember, there are deep bleeds. Deep bleeds means what? Hematoma formations, hemarthrosis, like the bleeding in the joints. So primary disorders give superficial bleeds. Secondary disorders give deep bleeds. Now, whenever someone have superficial bleeds like petechia and purpuras, we know that the problem can be in platelets, can be von Willebrand disease, or can be vascular problems. You can see whenever the problem is with the platelets, so there could be two conditions. Number one, the platelets are less or there is low platelet count, thrombocytopenia is there. Number second, the platelets can be normal but are not functioning well due to some other problem. Okay, so the normal platelet count is there. So you can see when there is thrombocytopenia, what are the causes? Number one, there is decreased production, aplastic anemia, which basically decrease all the cell lines like uh, RBCs, WBCs, and platelets. Aplastic anemia, it could be it could be as a result of parvovirus B19 infection. It could be due to many drugs, or there could be increased destruction, like immune thrombocytopenic purpura, in which there is immunity related destruction of the platelets, or again the same thing, TTP and HUS, which we were discussing in anemia. So thrombotic thrombocytopenic purpura or hemolytic uremic syndrome, or there could be HIT, which is heparin-induced thrombocytopenia. Of course, we are not going to discuss these or this one, HIT, because it is very, very, very rare in the in the babies. Or there could be hypersplenism, like the spleen is overworking and it is destroying more and more platelets. When the platelet count is normal, then it could be hereditary or acquired causes which are not allowing the platelets to work properly. For example, there are two syndromes called as Bernard-Solier syndrome, which is a glycoprotein 1b deficiency, which are important for the platelets to join, to aggregate, and Glanzmann syndrome, in which there is glycoprotein 2b3 deficiency, which again, so one of these they cause adhesion, one of these cause activation. So simply the platelets have to attach between each other, and the platelets have to attach with the vascular wall. So these glycoproteins helps in that one. Or there could be acquired causes like drugs, like aspirin, alcohol, NSAIDs, uremia, like for example chronic renal failure can give uremia, or myeloproliferative disorders. Whenever it is vascular problems, so it could be hereditary, like Osler-Weber-Rendu syndrome, in which one on the body there are multiple telangiectasias, so they can bleed, or connective tissue disorders, or it could be acquired, like purpura simplex, in which like there is easy bruising, senile purpura, um, Hinox-Collin purpura, scurvy, Cushing syndrome, infections of drugs. So these are the causes of primary hemostasis. Uh, Now, to tell you, like for example, what is ITP? Immune thrombocytopenic purpura. What happens? Like it can occur in adults. It can occur in childhood. So simply the platelet count get decreased, right? Like it comes less than 100,000 per liter. So what happens? When the platelets are less, so they become easy to bleed. So they may present with superficial bleeds. Okay. Now, what is happening? Basically, there is immune mediated destruction of the platelets. So how we treat this one? We keep on monitoring the babies and see. Many times, this thing occur after some viral infection. So we keep on monitoring them, like what is their platelets counts, and we can give them corticosteroids, we can give them antifibrinolytic drugs. Sometimes in emergencies we can also give them platelet transfusion, but we cannot give platelets regularly, because remember it's immune mediated. So even if you will provide the platelets from outside, the immunity are going to destroy them. So this is how it present with. And if it is like too much long standing, we can go for splenectomy. We can remove the spleen. So this is how we treat them. TTP, or thrombotic thrombocytopenic purpura, and HUS, it is hemolytic uremic syndrome. Uh, Basically what happens in TTP is there is a deficiency of metalloproteinase. That one basically, you can say, there is von Willebrand factor. So von Willebrand factor is there. So this metalloprotease basically break down that you can say the large particles of von Willebrand factor. So whenever they don't have that metalloprotease, what happens? Like the von Willebrand factor cannot be broken down to smaller one. So due to that, there could be non-immune mediated hemolysis, or microangiopathic hemolytic anemia, with some neurological signs as well, with thrombocytopenia. And HUS, hemolytic uremic syndrome, basically occurs in children. It can occur in adults as well. Like when the patients they get infected with E. coli, not just E. coli, but most of the time it is E. coli. It could be other viruses or bacteria. So what happened? They present with severe thrombocytopenia and okay, this hemolytic uremic syndrome, guys, we are going to discuss in very much detail. Okay, but in some of the next lectures. So this one, I wanted to tell you like exactly what's going on in these patients and why they develop this thing. Okay, so we are going to discuss one soon. Okay, like not in this lecture but later on. Von Willebrand disease, like what happens in them, this is the most common inherited bleeding disorder, and it is autosomal dominant, and they are present with superficial bleeds, menorrhagia in females, and epistaxis. So one Willebrand factor, by the way, it is needed for the platelet adhesion and aggregation. So it's playing a very important role in the primary hemostasis, or the first stage of hemostasis. So simply, the treatment of these patients is simply we can provide them with von Willebrand factor. So anyhow, I would rather show you two very important things. See, again, this is the child with abnormal bleeding into the soft tissues, mucocutaneous or following surgery. So this is a different approach. You can say there could be acquired causes, there could be inherited causes. Acquired causes, it could be vitamin K deficiency, it could be liver disease, it could be thrombocytopenia. Consider age of onset, family history, bleeding history, and pattern of bleeding. See why they are saying family history is very important. For example, hemophilia A and B, they run in family. Von Willebrand factor, it runs in families. Bleeding history and pattern of bleeding. Pattern of bleeding, why it is important? Because you can differentiate between either it's primary, either it's secondary. Inherited disorders. So these are the acquired causes and these are the inherited disorders. It could be hemophilia A, it could be hemophilia B. They both are X-linked recessive disorders affecting males. Presentation of severe disease, usually with recurrent spontaneous bleeding into the joints and muscles. I told you hematomas and hemarthrosis. So, how we treat? Remember, it's factor VIII deficiency, it's factor IX deficiency. Provide them, the problem will be solved, right? And von Willebrand disease, I told you already that it is like deficiency in von Willebrand factor, autosomal dominant, usually mostly, and von Willebrand factor is needed for the primary hemostasis because it is needed like when there is adhesion and aggregation of the platelets. So this one, because this is the deficiency of the clotting factors, so this one is a problem of secondary hemostasis, so deep bleeds are there. Now von Willebrand factor is needed for the primary hemostasis, so superficial bleeds will be there, right? So see, mucosal bleeding, epistaxis, menorrhagia, right? Treatment, again, provide them with von Willebrand factor. What we give them? We give them DDAVP, desmopressin, that's it. So what desmopressin do, by the way, it enhance or it increase the release of von Willebrand factor. Okay, it comes in nasal spray forms as well nowadays. So this is what happens. So now the important thing, guys, is what? Okay, so two conditions which I told you we are going to study in details, right? I told you two conditions which we are going to study in detail. One is we are going to study Hinox colon purpura, and one condition which we'll study is hemolytic uremic syndrome, right? So of course, like both of these two conditions, I am going to talk about them in detail. Okay, so not in this lecture, but later on. The important thing about what you can say, where I was in pediatrics. So yes, okay. The important thing which I wanted to tell you here is simply any one, any like any patient who is coming, okay, with petechias and purpuras. So petechias and purpuras are what? They are superficial bleeds. So now, if you again go to this one, so these are all the cause of superficial bleeds, right? So what we do is, first of all, we check either there is thrombocytopenia like the platelets are or less, or it is non-thrombocytopenic, like the platelets are normal. So you can say what I'm talking about. Anyone who comes with superficial bleeds, you have to see either the cause is this one or the cause is all this one, right? So see, whenever it is thrombocytopenic, one of the causes ITP, which I already explained you, it is immune thrombocytopenic purpura, mostly occur after viral infection, and um, they have widespread dickpetekia and purpura, distinguished from acute leukemia and aplastic anemia. Check their blood film, do the bone marrow examination, right, which is not usually required, by the way. And in acute phase, benign and self-limiting in about 80% of patients. Okay, when it is becoming chronic, we go for splenectomy. We remove the spleen simply. And thrombocytopenia could be occurring leukemia. Now, leukemias, the blood cancers. Like whenever there is leukemias, what is going on? Like all the cell lines are going to be depressed, either depressed or either they will be abnormal. So of course, like leukemias, they present with anemia with thrombocytopenia. So it could be leukemia, it could be disseminated intravascular coagulation, and other causes are uncommon. And whenever it is non-thrombocytopenic, consider Hinox colon purpura. We are going to study this one in detail. It could be sepsis, it could be trauma. So this is how we approach the patients in pediatrics about the possible causes of anemias, okay, and the possible causes of bleeding. Now, guys, like uh, I took you in some other way. I'm not talking about how the thing is written in the books, but why I took you in this way. See, the patients, they present with signs or symptoms. So for example, if someone presents with the signs of or symptoms of anemia, what are the directions you can take? Or if the patients will come with petechias or purpuras, what are the direction you must take? So what are the investigations you will do? What are the things you will ask on history? What are the investigations you choose? And of course, we have to treat the underlying causes. Okay, so this is how the things are meant to be taken. So, of course, like other than that, uh, there's a lot of conditions, okay, which are rare, though they are rare. So, of course, we are not going to discuss them. Okay, then one of the thing which we can cover in this lecture is how we approach a patient child with suspected immunodeficiency. Now, immunodeficiency syndromes. I would start the story from here. Okay, to tell you this topic, um, you guys, if you want to understand again, pathology is the key for this thing. Now, immunodeficiency disorders are, uh, of course, like the disorders with the immunity. The immunity is not proper, and immunity um, is the key which is fighting what you can say all the infections in the body, right? Now, if we will talk about immune deficiency, immune deficiencies can be primary, which are uncommon, and they can be secondary, which are more common. I always say that, who are the immunocompromised people? Anyone who have HIV, who is having malignancy, who have chronic disease, extreme of ages, anyone who is taking immunosuppressive drugs, anyone who's taking corticosteroids. Okay, how the babies they present with immune disorders? See, they have recurrent bacterial infections, they have severe infections, and infections that present atypically. Now, many of the conditions, when you will study AIDS, you would know that many of the disease organisms like Pneumocystis carinii pneumonia, or like the new name is Pneumocystis jirovecii. They cannot infect the normal immunity people. They can infect the people who have AIDS, for example, because their immunity is not fine. So, in infections caused by an unexpected or opportunistic pathogen, right? Severe or long-lasting warts or generalized molluscum contagiosum. Now, this one is a viral infection. Extensive candidiasis. Now, candidiasis, which is a fungal infection, is quite common, but here it is written extensive, so it means like on multiple parts of the body. And it could be complications of vaccination, like someone baby who get a vaccination like BCG, and they got a complication out of that. And that's the reason we don't give live vaccinations to the to anyone, not the kids, like to anyone who are immune deficient. Abscesses of internal organs like recurrent subcutaneous abscesses or prolonged or recurrent diarrhea. So this is the presentation of the immune deficiencies, right? This is how the child present. Now, the immune deficiencies are classified into primary, which are uncommon, and secondary, which are common. So, of course, the primary one mostly are inherited type of disorders, which are runs in families, and they are more common in boys because most of them are either X-linked or either autosomal recessive. So remember, primary immune deficiencies are more common in boys. Okay, so uh, now these are the investigations which we can do to catch anyone with primary immune disorder. For example, we can uh, do the full blood count or CBC. We can check the lymphocyte count like CD4 count, CD8 count, CD3 is like the total cell T count. Uh, we can check the ability of the T cells to proliferate in response to mitogen. So this is to check the cellular T cells. And then we can do some tests to check for the antibody or humoral response of B cells. Like we can measure the immunoglobulins levels, we can measure the IgG subclasses or specific antibody responses, like we can give uh, tetanus and pneumococcal antibodies and stuff like this, right? There are some tests to check for combined C and T cell investigations. So of course, like combining all these things. Okay. There's a condition called as severe combined SCID, immunodeficiency SCID. Then there are tests to check for the neutrophils. Like we can check for the neutrophil count. We can then do more tests. Okay. So this thing, and then we can do some tests to check the complement system as well. Like simply we like the test to we are discussing about the test to detect the primary conditions. Now, um, if I will tell you more in this one, uh, of course, we cannot discuss the secondary immune deficiencies, guys, because it is HIV, it is drugs, it is malignancy, things like this. This is the clinical presentation of primary immune deficiencies. You can see the T cell defects, how they present. Now, whenever the babies they have T cell defects, they present with severe or unusual viral and fungal infections and failure to thrive in the first month of life. For example, severe bronchiolitis, diarrhea, oral thrush, and pneumocystis jirovecii, it's the new name, or Keriniae, which is the old name. And what are the examples of that? One thing is called as SCID, severe combined immunodeficiency. HIV infection, it could be Wiskott-Eldridge, it could be DCOR syndrome. And now, DCOR, George, is the one which, like in the previous lecture, I was talking about chromosomal abnormalities, genetic abnormalities. This one occurs when there is, it is also called as catch-22, when there is a small deletion in chromosome number 22. That's what is also called as catch-22, CATCH. And catch is basically what happens, cardiac and all those abnormalities. Duncan syndrome or ataxia telangiectasia. And it could be a B cell antibody defects. It present in the first 2 years of life, beyond infancy. Now, why beyond infancy? Because when the babies are born, they take a lot of antibodies from their mother, so they are enough for them for a while. But later on, when they cannot develop their own, so they may present with severe infections. Okay, so the examples are, you can see like the X-linked Bruton, Agammaglobulinemia, it's common variable immune deficiency. Hyper IgM syndrome or selective IgA deficiency, it is the most common primary immune defect, right? IgA deficiency. It could be neutrophil defect. So, like these are the patients who present with multiple abscesses. Okay, because remember the neutrophils are defective. So when the neutrophils are defective, they are the first line defense. So now these patients they mostly present with granulomatous diseases. Then there could be leukocyte function defects. Uh, these are the presentation, like they present with delayed suppression of umbilical cord, delayed wound healing, and the example is leukocyte adhesion deficiency (LAD), and there could be complement defects. So they present with recurrent bacterial infections or recurrent meningococcal infections, early complement component deficiency or terminal complement component deficiency or mannose binding lecithin deficiency. So anyhow, by the way, in this slide, like mostly, as I told you, uh, it is immunodeficiency type of things. They are not, we don't teach, right? So, but I'm just like giving you an idea how they present, okay, and just to give you an overview as well. So in this slide, like of course, like you are going to find, for example, um, wait, the thing is not clear over here. Okay, onset and any and complement effect and all this stuff, right? Physical examination. Like what I wanted to show you is, um, like I don't know. I will change the color of the slide, or you can do it yourself. Okay, wait. Yeah, the B cell deficiency things and about SCID and all this one, right? Okay, so how we manage any immune deficiency? Of course, like anyone who have any immune deficiency, any primary immune deficiency, of course, the treatment is we give them what you can say um, prophylactic drugs like antibiotics, antifungals, antivirals to prevent them from infections. Uh, Whenever they have infection, we give them broad spectrum antibiotics as soon as possible, so that like the infection should not become serious. We keep on screening them for end on organ damage. If they have some antibody deficiencies, we can give them replacement immunoglobulins, and of course bone marrow transplantation can be given, right? So that's the thing, and nowadays again they are working for gene therapies, and these are the causes of secondary immune deficiencies. Like of course they are different conditions: extreme ages, environmental stress, HIV, malnutrition, okay, all these things, immunosuppressive drugs, corticosteroids and stuff like this. So thank you so much guys for listening to this lecture. I will see you in the next lecture. Thank you.